Buongiorno a tutti. Good morning. First of all, I would like to thank Dr. Roberto Valcavi for inviting me to this meeting. Roberto Valcavi is a pioneer of the minimally invasive therapy, US-guided therapy of thyroid nodule. And this venue is particularly interesting and dreaming, and is a witness, in my opinion, of the genius of a million people. The first session will be held on the diagnosis and management of thyroid lesion, and the first presentation, the first lecture, is by Dr. Massimiliano Andrioli from Rome. He is the founder and the director of Endocrinologia Oggi, and is based on the thyroid ultrasound and fine needle aspiration biopsy technique. Please, Dr. Andrioli.
Thank you very much. First of all, I want to thank Dr. Valcavi for inviting me to have a talk about interventional techniques and on thyroid ultrasound. This is an audience of experts on thyroid ultrasonography, so probably I'm going to bore you. Anyway, my presentation is divided in two parts. In the first part, I'm going to describe thyroid ultrasonography as a useful tool for risk stratification of a thyroid lesion, and in the second part, as a useful tool for interventional procedures. So, what is a thyroid lesion? It's a discrete lesion within the thyroid parenchyma, clearly distinguishable from the surrounding thyroid tissue. And due to the increased use of ultrasonography, we assist to an increasing number of incidentally discovered thyroid lesions. So this figure shows the increased prevalence of thyroid lesions discovered by neck ultrasound compared to neck palpation. So that some author wonders how to handle this epidemic of thyroid lesion. And probably, first of all, we should reduce the number of total number of ultrasound examinations we usually perform, and we should select patients to undergo ultrasonography. And following the ACE/ICH-AME guidelines, ultrasound thyroid evaluation is recommended for patients who are at risk for thyroid malignancy, who have palpable thyroid nodule or goiters, or who have lymphadenopathy suggestive of malignant lesions. Now, once understood who should undergo ultrasonography, we need to clarify how to write a thyroid ultrasonographic report, because a good report should use, in my opinion, an universal standardized terminology for description of thyroid lesions. It should reduce the variability in ultrasound reports among operators, and should help endocrinologists or operators to take reproducible decision on thyroid lesion, and probably represent the best tool to select the nodule to undergo fine needle cytology. In fact, some years ago, I published a paper on European Thyroid Journal on standardized ultrasound report for thyroid nodules, highlighting the endocrinologist viewpoint. In this report, I described the most important ultrasonographic parameters to be evaluated. These are number, position, shape, composition, echogenicity, echotexture, margins, vascularity, size, and, if possible, hardness of each thyroid lesions. What about total number? We know that a good ultrasonographic report, probably in multinodular goiters, should detail the nodule bearing the ultrasonographic feature associated with malignancy, rather than describe all the lesion or the largest one. The position, we know that has no relevance in the differential diagnosis of thyroid cancer, but we should take particular attention in subspecies subcapsular lesions. In fact, regarding a capsule relationship, we can describe a deformation, a capsule infiltration when there is a clear interruption of capsular hyperechogenicity, or in some cases, invasion of adjacent tissues that is more frequent in invasive tumors like anaplastic carcinoma, thyroid lymphoma, etc. These are some pictures showing a capsule deformation. Another one, another capsule deformation. Here, instead, we can see a clear interruption of capsule hyperechogenicity, and it's more clear here with a clear invasion of surrounding tissues. For shape, we can describe nodule as oval, round, irregular, or taller than wide. When the anteroposterior diameter is greater than the transverse one, we know that this is a feature associated with malignancy with a high specificity and a low sensitivity, and taller than wide is probably due to a growth in an anti-gravitational way compared to benign lesion. And this is a picture of taller than wide lesion. Regarding internal content, we can describe a nodule as solid, mixed or complex, mainly solid, mainly liquid, cystic, or spongiform. And there are some images of a cystic lesion, a complex, mainly liquid lesion, and complex, mainly solid liquid, mainly solid lesion, and a spongiform lesion. For echogenicity, instead, we can describe as anechoic, asechoic, hyperechoic, hypoechoic. Remember that more than half of benign thyroid lesions are hypoechoic or markedly hypoechoic. These are some examples. I go fast because hypoechoic lesion, an hyperechoic lesion, and markedly hypoechoic nodule, and some picture of isechoic nodule. Echo structure, instead, is not decisive in the differential diagnosis of a thyroid cancer, and we can describe a nodule as homogeneous, finely inhomogeneous, or markedly inhomogeneous. More important instead are calcification. We can classify microcalcification as small point-like hyperechoic spots without posterior acoustic shadow that are more frequent in large papillary tumors and less in small papillary tumor, and it is a suspicious feature. Macrocalcification instead are large, coarse, and often associated with the posterior acoustic shadow, and we can find them in both whole benign lesion and in cancer. Some example of microcalcification. This is small papillary thyroid carcinoma, a nodule with macrocalcification, and here we can see eggshell calcification, complete or incomplete eggshell calcification. I want to introduce the hyperechoic spots of uncertain significance when it's not so easy to distinguish between microcalcification and colloidal spots. What about margins? Margins can be well-defined, pool-defined, regular, irregular, when irregular, spiculated or lobulated, and margins definition are very important, but unfortunately is the ultrasonographic parameter with greater inter-operator disagreement. And some picture of a nodule with blurred margin. This is a cancer with irregular spiculated margin. This is another one with irregular polylobulated margins. And what about vascularity? A flow, we know, is accessible with color Doppler or power Doppler, and we can describe a nodule with absent perinodular, intranodular, or peri-intranodular flow, but vascularity has no role in the differential diagnosis of thyroid cancer. In fact, it is not reported as a suspicious feature in the main risk classification. These are some pictures about vascularity and size. Size, we know that we should, each nodule should be measured in its 3 diameters, and the risk of malignancy does not change in general with the size of the nodule, but it is useful to evaluate the volume increase defined as a 20% increase in its diameter or a 50% increase in its volume. It is a common opinion that cancer grows more than benign lesion, but we know that most of the benign lesion can increase volume over time, and papillary thyroid carcinoma can remain unchanged for years. In case of fast increase, instead, we should think about aggressive neoplasm, like medullary or anaplastic carcinoma or thyroid lymphoma. 2 slides for elastosonography. That is a sort of electronic palpation. Is a recent ultrasound technique that is able to provide information on the hardness of a nodule, but elastosonography does not replace ultrasound, but provides complementary information regarding the hardness of a thyroid lesion. In fact, it's not considered in ultrasonographic risk stratification usually. And this is a picture of strain ratio between a nodule in a real-time semi-quantitative elastosonography. Now, we have many ultrasonographic parameters to evaluate, but how to combine all these ultrasonographic features? We know that some classification systems have been created to stratify the risk of malignancy and to identify nodules that require fine needle aspiration cytology. In fact, since 2002, Kim first reported a combination of 4 suspect ultrasound features: microcalcification, irregular or microlobulated margins, marked hypokegenicity, and tolerant the Y shape. And since then, many other ultrasonographic risk stratification systems have been developed. Thyroids, we know the American, the British, the Korean, the European thyroids, the American College of Radiology thyroids, and the ACIC Italian classification system that is supported by 6 Italian societies. And just to word on the last one, it divides the nodule in 3 classes. Low-risk lesion, when the expected risk of malignancy is about 1%. Intermediate risk with 5 to 15%, and high risk with the risk of 50–90%. Okay. Now, we have a lot of scoring systems at the moment. The American, the Korean, the Italian, the American College, the European. But which classification system should be used? My answer is easy. It's not an answer. It's at least one. Why? Why? Because this is a paper published on the use of a scoring system in Italy. As you can see, only 27% of ultrasonographic reports are written using a scoring system. So probably we have to decide to use one of them. But which is the best one? We know that there are many papers comparing different classification systems. And this is not the focus of this talk. Anyway, regardless of which is the best one, in my opinion, the presence of too many classification systems at the moment may even cause greater confusion, because in Italy, someone uses the British classification, someone the Italian, someone the American College. So it's not so easy to compare. So fortunately, I'm not sure, but I think that a unique classification system is needed. It probably will be proposed with the agreement of many international society at the next International Thyroid Congress that will be held in China the next year. Probably we are going to have one unique classification system to be used from everybody. Now, in the second part, I'm going to describe thyroid ultrasonography as a useful tool for interventional techniques. Sorry, it's my Mac. And I want just to give a general overview of the various interventional techniques that will be described in detail later. And the main procedure are FNAB, percutaneous ethanol injection, and thermal ablation. What about fine needle aspiration? We know that fine needle aspiration should always be performed under ultrasonographic guidance because it makes the procedure safer, more reliable, and more accurate. And the use of ultrasonography guidance is recommended whenever possible for whole thyroid nodule, even for palpable thyroid nodule. FNAB method, we can use a thin needle that can be attached to a syringe for aspiration or not attached to a syringe for capillarity. We can have a coaxial technique or a lateral approach. For cystic nodule, FNAB has both diagnostic and evacuative purpose. And for complex thyroid nodule, we should sample the solid component of the lesion, and we should submit both the FNAB specimen and the drained fluid for cytological examination. For large size nodule, we should sample peripheral and possibly solid area to avoid fluid or necrotic zone. Now, two slides to ultrasonography as a useful tool for administration of ablative therapies. We know there is a big interest, as shown by the number of publications on these interventional techniques in the last years, and towards on percutaneous ethanol injection, that is a safe, following the ACIC guidelines, is a safe and effective therapy for thyroid cyst and complex nodule with a large fluid component. We should sample the solid component of this lesion before doing PAI, and it is recommended as the first-line treatment for relapsing benign cystic lesion, but it's not recommended at the moment for solid nodule. This is the equipment for PAI, and we know that during the procedure, the patient undergoes aspiration and emptying of the cystic nodule by thin needle, and under ultrasound monitoring, a volume of ethanol is injected and then reaspirated. The procedure takes about 20 minutes, and once it's completed, the patient is required to be observed for 1 hour, 2 hours. It can have some minor or minor side effects, but in general, the procedure is safe, rapid, and well tolerated, and does not require usually medical support. For thermal ablation, just 2 slides. Thermal ablation are not surgical procedure for the volume reduction of large thyroid nodule and improvement of local pressure. This is another picture, okay? We should consider, following the IC guidelines, we should consider laser or radiofrequency ablation for the treatment of solid or complex thyroid nodule that progressively enlarge or are symptomatic. And we should repeat fine needle aspiration for cytological confirmation before thermal ablation treatment. Just 2 words. Remember that for thermal ablation, for radiofrequency thermal ablation, we can usually use a transisthmic approach. And in general, the last slides, the procedure can be considered as well tolerated and effective for the persistent reduction of large benign nodule. Thank you for your attention.
Thank you, Dr. Andrioli, for your presentation, and thank you also to stay in the allowed time. The question?
Thank you very much for this beautiful presentation. Paolo Vitti, Pisa. I have a comment about different classification systems for evaluation of the risk of the nodules. I agree with you that there is much confusion. However, I think the most important thing is to choose one of the 2 strategies. I mean, several systems employ 5 class risks, and some 3. I think that those that use 3 classes are much more useful. The other thing is that any center must have experience, at least with one classification, use that, and compare this classification with results. It's like the classification systems we have for fine needle aspiration. We know that there are at least 3 or 4 different classification systems, so you must have familiarity with one of those classes and have your pathologist who is always using the same classification and have experience with that. I think this is the best thing to do.
Yeah, I agree with you. In my personal experience, I use the Italian classification in 3 classes, and there are many other risk stratification, and in my opinion, it's important not only to distinguish between the classification in free class or for, but even think about the aim of this classification, because generally these ultrasound risk classification systems are developed to reduce the number of unnecessary fine needle aspiration.
Right.
So there are some publications about comparing the various ultrasonographic risk system, and in my opinion, the best one in reducing this number, probably by literature, is the American College of Radiologists, in reducing the number of unnecessary fine needle aspiration. Probably is the best rule-out classification system. Yeah. But in my opinion, it's difficult to apply this kind of classification clinical practice, because it is based on number. So in Italy, it's very difficult to have too much time to assign a point scale to each ultrasonographic feature and to give
just to use one system and have experience with that. This is my advice.
Yeah. I agree with you.
Thank you, Massimiliano, for a great presentation. I'm Stephen Hodak from NYU Langone Health in New York. I agree that, we don't always get to choose which system is going to be used for grading thyroid nodules. Sometimes that's a decision that's made by radiology groups, and we have no control over that. I think, though, what we as individuals and we as organizations need to demand from the people that grade thyroid nodules is some evidence from them about how reproducible and how accurate their grading is. So there can be many effective systems that, if implemented poorly, are useless. And you might argue this system is better than that system, but if a group is very successful and very accurate in giving you a correct evaluation of a nodule, we should be able to know that. What's the value of their grading? And I think currently they don't do that. So instead we argue about, is TIRADS better than the ATA system, or is the ATA system better than the European TIRAD system? It's really more about how effective does an individual use that system to give you the correct answer.
For this reason, my hope is that in the future we are going to have one unique, compulsive ultrasonography risk. Probably in the next year will be proposed, supported by even more society. So I agree with you, but I think the solution, the final solution, will be to have one unique for everybody, for endocrinology, for radiology. Not maybe it's a dream.
Well, but I'm from New York, so I'm a cynic. So I'm not sure that's going to happen. But whatever system anyone chooses to use, they should be able to tell me how accurately they can use it. And this no one does now. And so I think that's a problem.
Now, this is my hope, non-certain. Okay.
Thank you, Dr. Hodak. Are there other questions? No, I have a single question for Dr. Andrioli. In fine needle aspiration cytology, how many passes usually you do?
It depends. Usually, in my experience, I do 4 or 5 passes, but it depends on the quantity of material I'm able to take by fine needle aspiration. So it ranges. It depends on the quantity of material I can.
And you have the pathologist working with you at the moment of the...
No. But it would be great to have a pathologist. It's not always possible, but it's better to have a good relationship, even with a distant pathologist. But I usually give him a complete report on the ultrasonographic feature. I give him pictures. So it's almost like it was near me. So
yeah. Thank you.
So we move forward to the second presentation. Just before introducing the next speaker, just one word to personal thanks to testify my gratitude to Roberto for having, of course, organized this meeting, beautiful meeting, but also for having introduced me, Roberto, to the field of thyroid ultrasonography, I would say more than 2 years ago, probably. It's been maybe something like 20 years ago and even more. So after this personal thanks to Roberto, well, next speaker, Giorgio Gardini. Giorgio is the former head of the pathology unit of our hospital in Reggio Emilia. He has given a great contribution to the work, to our everyday work in thyroidology, in diagnosis of thyroid nodules, and this is another personal, how can I say, witness. In our hospital, thyroid report classification, classification of thyroid cytological report was introduced maybe in the 90s, if I remember well, so before the international classification reporting system were actually introduced, and this has provided us with a great help in our everyday work in diagnosing thyroid nodules. This was a very, very important tool. So Giorgio has a tremendous experience, and I think he will manage to share this experience with us this morning. Please, Giorgio.
Thank you, Andrea. Good morning to everybody. It's a pleasure for me to be here to speak with you about thyroid cytology. Am I the only pathologist? Yes, only pathologist. Final aspiration, cytology, is the best tool for the diagnosis of thyroid nodular disease. I think everyone agrees with this statement, but thyroid cytology must find space and meaning in the context of a multidisciplinary team, because by itself, without the discussion in multidisciplinary team, it loses some of its importance. I think that not everyone agrees with this statement. Somebody thinks that for each cytologic diagnosis, there should be a precise clinical action. I disagree. Here to have two examples. The first, a cytological report of doubtful lesion could lead to different therapeutic strategies. In a young woman with a nodule 2 centimeters in diameter, not increasing the last year, this report will suggest only follow-up. In an old man with a nodule 5 centimeters in diameters, rapidly increasing in recent month, the same report will suggest surgery. Second example, a cytological report of neoplasm, positive, will not necessarily lead to surgery, but if the lesion is a small intrathyroid papillary carcinoma, the follow-up hypothesis may also be accepted. Thyroid cytology is a method characterized by high sensitivity, but at two limitations: inadequate sampling, undeterminate diagnosis. Inadequate sampling, to reduce the number, it is essential to perform the needle aspiration using an ultrasound guideline. It is obvious. The needle aspiration and ultrasound guide is also essential to be sure that the colloid present in the smear comes exclusively from the target nodule and not from the adjacent parenchyma. The colloid is one of the most important elements of thyroid cytology, and the relationship between colloid and cellularity is the clue to decide whether a lesion is benign, ductal, or malignant. We will see this later. Undeterminate diagnosis. This problem is common in all diagnostic cytology, from vaginal pap test to mammary cytology, to mention the most known. The undeterminate diagnosis, those not clearly benign or malignant, remain in a gray area and create problems of how to manage it in the multidisciplinary team. Also, for this problem, the diagnosis category has been introduced. They were born after 2000 with the aim to standardizing cytological description and terminology. The main classification are American Bethesda system, 6 categories, British Union Kingdom Royal College of Pathology, BTA is British Thyroid Association, is the acronym we will use. 5 categories, Italian, CIAPEC, 5 categories. In this table, we have the comparison of the main classification. The first is British, Bethesda, Italian. There is also Australian and Japanese. The main difference between this system is the definition of the gray zone that includes both lesion doubtful for papillary thyroid carcinoma and lesion doubtful for follicular neoplasm, adenoma versus follicular carcinoma. Reggio Emilia uses the English classification, BTA, which, in our opinion, is the best to distinguish the lesion doubtful for papillary carcinoma, Type 3A, for those doubtful for follicular carcinoma, Type 3F. This is a tribute to the Queen. This is the guideline for management thyroid cancer, the British Thyroid Association. In this, there are the classification BTA. In this table, we emphasize the gray zone. The first is English, CIAPEC Italian, Bethesda. The gray zone is different. In British classification, there is the clear separation between lesion doubtful for PTC, papillary thyroid carcinoma, and those doubtful for follicular thyroid carcinoma. In Italian classification, CIAPEC, that is very similar to Bethesda, the gray zone is divided into 2 subgroups according to the risk of malignancy. Tier 3A, Tier 3B. Tier 3A, low risk, indeterminate low risk lesion. 3B, indeterminate high risk lesion. 3A, risk of malignancy less than 10%, suggests clinical action, repeat fine needle aspiration, or follow-up. Tier 3B, a risk of malignancy between 10 and 30%, suggests clinical action, surgery. In the classification of CIAPEC and Bethesda, there is not the separation between lesion doubtful for papillary thyroid carcinoma and follicular thyroid carcinoma. I think, is my opinion, CIAPEC classification is comparable to the American classification of Bethesda, which reflects the need of a sort of defensive medicine that I believe should be avoided as much as possible. To further reduce the gray zone, is the myoperimeter and determinate diagnosis. To further reduce the gray zone of type 3F, repeat, lesion Duffur for follicular carcinoma, based on our experience, we codify the following criteria. If colloid is moderate and cellular height of is colloid scant and cellular is moderate, different between cellularity and colloid, we consider the kind of cellularity. If urte cell or microfollicular arrangement prevail, our diagnosis is type 3F, otherwise it is type 2. If cellularity is high and colloid is scant, the diagnosis is type 3F, whatever the cellularity. If colloid is abundant, the diagnosis is type 2, whatever the cellularity. In this table, you can see what I said before, what zone, the difference between type 3F and type 2. In this table, there is the gray zone, second CAPEC, and you can see that the gray zone is amplified. In our experience, we tend to diminish the gray zone. Our results, in the period between 2016 and 2018 in Reggio Emilia, we had a percentage of diagnosis that fall in the gray area of less than 6%, with 12 of inadequate, 78 of negative, 1 of suspected, and 3 of positive result. Note that in 2018, the number of undeterminate diagnosis is less than 5%. Is a good result. Using our classification in Reggio Emilia, each year we evaluate cytohistological correlation to verify false positive or false negative cases. This is the lie, and sorry, is in Italian. You can see that there aren't false positive in type 5. The only false positive is in type 4. There are 2 false negative in type 1, indeterminate, and 4 in type 2, benign. The false positive is in type 4. It was an arterial cell adenoma with very pronounced regressive aspect. Of 6 false negative, 2 cases were inadequate. Type 1, both micropapillary carcinoma, they were incidental finding in surgical specimen. 4 cases in type 2, 2 micropapillary carcinomi, they were incidental finding in surgical specimen, 2 minimally invasive follicular carcinoma, 1 incidental finding in surgical specimen, only 1 was a true false negative case for a wrong evaluation of the amount of collagen present in the smell. Molecular biology. To solve the problem of undeterminate diagnosis, additional predictive parameters of malignancy were sought to be associated with cytological examination. In recent years, following the discovery of genetic alteration involved in development of the differentiated thyroid carcinomas, molecular analysis applied to thyroid cytology and been proposed. According to Italian Association of Oncology Medicine 2017 guideline, the main alterations are the rearrangement of transmembrane receptor with tyrosine kinase activity, the activating mutation BRAF RAS in PTC, the rearrangement of PAX8, PPR gamma, and the activating mutation of RAS in the FTC. In Reggio Emilia, also in consideration of the low percentage of undetermined diagnosis, less than 5%, we limit ourselves to the search for mutation BRAF on the cytological material only in type 3A, not in type 3F, or type 4 diagnosis with excellent result. Let's see how we do it. It is a very simple method. We start from slide. It is necessary to have a blade and an Eppendorf. We scrape the slide to take the cell, put them in the Eppendorf, and send them to the laboratory to biology molecular. This is a case, female of 31 years, nodule of the right thyroid lobe. This is the only image of cells. These are the cells we see in the slide. A tag magnification, we appreciate the nuclear characteristic with some growths, but not intranuclear cytoplasmatic present inclusion. The diagnosis, the cytology diagnosis was type 3A, but with BRAF mutation, it becomes papillary thyroid carcinoma. Our experience, 75 cases of thyroid finite aspiration subjected to BRAF V600E biomolecular mutation research at the Molecular Biology Laboratory from 2014 to 2017. These are the results. In 39 cases, there are not mutation. In 36 cases, there are mutation. All cases operated, 31, is papillary thyroid carcinoma. In cases not mutated, there are 3 perplasia, 11 adenoma, 1 hyaline trabecular tumor. This is the last. In this last table, you can see the percentage of papillary thyroid carcinoma without mutation in our cases in this clinic type 3A and type 4. Mutation 74%, no mutation 26%. I finish. Thank you for attention.
Thank you, Giorgio. So there's time for a Q&A, questions. Well, I want to break the ice with one question. What about the learning curve for cytologists? Because we are always listening to learning curve for fine needle aspiration, biopsy, and for the perspective of the endocrinologist or the radiologist performing. What about how long, what kind of experience is required to become a good cytologist, thyroid cytologist? Quanto tempo, la curva di apprendimento per un citologo?
Yes, a cytology must study general cytology, then specialize in thyroid cytology. It's important to know the general cytology, mammary, salivary gland, and other. Then it depends on the teacher, dal maestro.
Yeah, so it's important to find a good school, I mean, a good teacher, and to practice in a large hospital, I think so.
Yeah.
Quanto tempo? How long the time to become, to feel, how can I say, to rely on your own experience?
I don't know. 1 year, 2 years depends on the medicine, the person.
Okay.
I don't know.
Thanks.
Over here. Thank you. Mario Stan, Rochester, Minnesota, United States. Very useful presentation. The challenge that we have at times with cytology comes from posterior nodules that it's difficult to define as intrathyroidal or extrathyroidal, and then to distinguish a parathyroid lesion from a thyroid lesion. So what's your clue in that respect? Sometimes we see Hürthle cell adenomas that turn out to be a parathyroid adenoma that was stuck to the thyroid.
For the sign, is adenoma thyroid or parathyroid is useful to search parathormone or thyroid in liquid. Also in the slide, we can use immunohistochemistry. Thyroid is tyrosine positive, parathormone, parathyroid is chromogranin positive. It is very simple with this ancillary technique.
That's what we're doing if we're clinically astute. We check a calcium and we check PTH. But sometimes the clinician might miss the clue that this could be a parathyroid, and then it's up to the cytologist. So I was looking to see if there's anything additional that you can say based on cytology alone, if there is a marker for parathyroid. But that's what we would follow, calcium and PTH otherwise.
Valcavi, Reggio Emilia. As early as in 1999, I believe, with Dr. Frasoldati, we published a paper on the importance of parathyroid hormone measurement in the needle washout. And all the time we see, where is Marius? Oh, Marius, yes. All the time, you have to check patients in advance and suspect a parathyroid lesion before doing the aspirate. And we found that the measurement of parathyroid hormone in the washout, in the needle washout, is terrific, in the sense that it gives almost 100% diagnostic results with 1,000 or 10,000 micrograms per ml in the washout. So all the time, I believe that Andrea, who's following my steps, is doing the same. All times I see a suspicious parathyroid lesion, I do in the same passes both washout for parathyroid adenoma, for parathyroid hormone, and cytology. This is my suggestion.
Morning, Donald Bergman from New York. What is your reading on a specimen that shows abundant colloid, only no follicular cells seen? First question, I've seen some cytopathologists read that as inadequate, others read it as consistent with benign follicular nodule. Second question, unrelated to the first, in a specimen that's mixed, some benign appearing cells, some malignant, have you looked at the genetic mutation in the benign follicular cells, and do you see the same mutation that you see in the malignant cells?
So you should repeat slowly your questions, please.
Well, your English is much better than my Italian, but I'll repeat slowly. So in a specimen that shows only abundant colloid, no follicular cells seen.
Cioè, quando c'è soltanto colloide abbondante.
Some cytologists read it as inadequate, repeat, others read it as consistent with benign follicular nodule. What is your opinion? That's the first question.
In between classification, there is the class Ty1C, is cystic, meaning only colloid. In my experience, when in aspiration there is only colloid, the lesion is benign. We must search with attention the presence of a group of cells. Sometimes there is the papillary thyroid carcinoma cystic, but in this case, some cells there are always. Then, colloid benign.
Okay. The second question, if you have a specimen with two populations of cells, some malignant, some benign, have you looked at the genetics of the benign cells to see whether they carry the same mutation as the malignant cells?
Cioè, se hai due popolazioni distinte nello stesso campione di cellule benigne e cellule maligne, che cosa fai?
If I sure that there is malignant cell, this cell determines the class. But I speak with Roberto or the interlocutor for study think very well, because there are two populations. In my experience, I saw very few cases. I don't have experience of two populations.
Thank you.
Richard Cluse, Verisight, United States. I wanted to follow up on the earlier parathyroid discussion and just to give a different perspective. The use of parathyroid washout is very useful when parathyroid nodules are suspected. The challenge is it requires the physician to suspect parathyroid at the time of the biopsy. And so in the US, the molecular testing has routinely tested for parathyroid with molecular methods. So you'll hear at my talk this evening, we routinely use a classifier to look for parathyroid in all FNA specimens sent to us. It occurs in about less than 1% of the thyroid FNAs sent that it turns out that it's parathyroid. But as you know, it can dramatically change the patient's care. Many of them are not hyperfunctioning. Some of them are hyperfunctioning. But with the volume of molecular testing being done in the US, we're finding hundreds of parathyroid glands that are being biopsied when the physician thinks it might be a thyroid nodule. So we found it very helpful in combination with other tests to help alter patient care. Same thing with medullary carcinoma. It's often not suspected, and yet we find them in biopsies by routinely molecularly testing them. Thank you.
Thank you, Richard. Thank you, Giorgio. So we can move to the last contribution of this session, which will deal with the nuclear medicine role in the diagnosis, in the diagnostic part of thyroid disease and thyroid nodules. And next talk will be given by Dottoressa Elisa Lodi Rizzini. She works in Bologna, a very important and renowned institution on nuclear medicine and radiotherapy, with a huge experience in thyroid cancer, actually. Please.
I'm very happy to be here in this very important and interesting meeting. And I want to extend the greetings of Dr. Monari, who apologized for not being here today. I will speak about the role of nuclear medicine in thyroid nodule, in diagnosis of thyroid nodule. Briefly, the definition, thyroid nodule is a common feature occurring very frequently in population with an increased prevalence after introduction of ultrasonography in clinical practice. Nodules can be palpable, non-palpable, solitary or multiple, and frequently is asymptomatic and is discovered during a health examination or a diagnostic exam performed by other reason. Can be benign, but from 5 to 10% can be malignant. So the primary aim is investigating thyroid nodules to exclude a thyroid malignancy. The American Thyroid Association says that only nodules more than 1 centimeter in diameter should be evaluated because have a greater potential to be clinically significant cancer. And on the contrary, nodules less than 1 centimeter require evaluation only occasionally. Radionuclide imaging provides useful information about the autonomous function of the thyroid nodule, and for this reason, because the evaluation is only for exclude the primary, the malignancy, is not a first instance exam in a thyroid node evaluation, but provides complementary information in association with the other diagnostic methods, supports clinical decision-making, and occasionally differentiates benign from malignant thyroid nodules with indeterminate cytology supported by immunocytochemistry or molecular testing. Scintigraphy has a higher sensitivity, but unfortunately a lower specificity. The nodule is functionally classified into hot nodules or hyperfunctional if there is present a focal increased accumulation of the radiotracer, warm or isofunctional, or cold or hypofunctional is focal photopenic defect devoid of the tracer uptake. Frequently, the nodule is cold more frequently, about 18–85%, and only about 10% is the cold nodule is malignant. The hot nodule malignancy potential is less than 1% of incidence. Scintigraphy can be requested before the cytological evaluation or after in the case of cytologically indeterminate nodules, and in this case the risk of malignancy is from 10 to 13%, so the early delineation in this case is essential because delays in diagnosis is associated with increased malignancy. American Thyroid Association says that thyroid scan should be performed only if the serum TSH is subnormal. The European Society of Nuclear Medicine declined to endorse this recommendation and says that normal TSH levels does not preclude the need for thyroid scintigraphy. This is the radiotracer, the main radiotracer used in nuclear medicine for the evaluation of thyroid nodules. Written in black, we can see the radiotracer that are indicated in the current guideline, while written in gray, the radiotracer that are not indicated in the current guideline because there are no sufficient data for accepted they use in routinary medical practice today. This schematically, we can see the different metabolic pathways in radioisotope imaging of thyroid nodules. On the central part of the image, we can see the iodine 123 and the technetium 99 pertenectated that enter the cell with the same sodium iodine symporter. And in the cell, iodine is organificated with thyroglobulin to form hormone, thyroid hormone. On the contrary, technetium pernectated is not organified in the cell and is not retained in the cell. On the right, we can see technetium MIB that enters the cell, takes advantage of its lipophilic nature, and in the cell it concentrates into the mitochondria. And on the left, Fdg that enter the cell through the transmembrane glucose transporter 1, and in the cell is retained because it's phosphorylated. It is phosphorylated. Now I will describe you the main tracer mentioned above. For many years, I started with iodine 132. For many years, this tracer was the main study agent for the assessment of thyroid gland function, but its characteristic, the beta emission and a long half-life of 8 days, the high energy gamma emission that give poor image quality and a high radiation dose to the patient. For this reason, it was gradually abandoned, and its use still remains for the evaluation of remnant metastatic disease after radioiodine therapy and for the uptake calculation for the hyperthyroidism. On the contrary, iodine 123 have a shorter half-life, is a pure gamma emitter, and it characterized by the persistent accumulation in the thyroid, and so it's traduced in a high imaging quality, and this tracer, for this reason, is the agent of choice for thyroid imaging, even if in the case of warm nodule on a technexio scan. In this image, in fact, we can see a case of discordant iodine and technetium scans. We can see at the left a hot nodule at technetio scan, and on the right, conversely, a cold nodule at iodine. At final histology, the nodule was a papillary thyroid cancer according to iodine and not to technetio pernettate. Technetio pernettate have a half-life of 6 hours and is eluted from the 99 molybdenum generator that is readily available in any nuclear medicine center. So is more available, is less expensive, and is faster performed because it is not retained into the cell because it's not organified. So a lot of nuclear medicine centers have adopted this tracer instead of iodine 123. This is an imaging of a very hot nodule, hyperfunctional to the technetium scan at the lower left lobe that almost entirely suppressing the remainder of the gland and the corresponding ultrasonography. This is the case of a plumber adenoma. On the contrary, in this technetium scan, there is a slight photopenic defect on the lower left thyroid lobe. And at Cytology, according to Italian consensus, was a tier 2, so a benign cold nodule. In this case, we have a decrease in inhomogeneous activity through the gland associated with multiple little hypofunctional areas bilaterally. The cytology is negative for malignancy, and we have a multinodular pathology associated with thyroiditis. Technetium 99 maybe is a tracer that is not indicated in current guidelines, but its role is emerging in a differentiated benign from malignant lesion. Especially when the nodules is cold on a previous iodine or technetium 99 pernettate scintigraphy on the basis of intensity uptake within the nodule and the assessment of an eventual increase in uptake within the nodule over the time in comparison with the radiotracer washout. So retention time and washout for normal tissue thyroid is calculated. This is the diagnostic accuracy of technetium MIB that increased by combined use of Specificity and its negative predictive values that reaches 100, only for non-oncocytic thyroid lesion. There are no recommendations in oncocytic lesion. This image is taken from literature and shows the different situation. In the upper, we can see technetium 99 scan, and below MIB. In figure A and B, we have both the cases negative, with negative technetium and negative MIB. At the cytology, was the nodules were benign nodules. On the contrary, in C and D, we have, as we can see, cold nodule on the technetium 99 scan and a positive MIB. And at histology, the nodule were carcinoma, papillary cancer. In figure E, there was a cold nodule and a positive MIB on the upper of the right lobe of the thyroid. So, summarizing, we can say on the basis of these studies that when MIB scan is negative, nodule is certainly benign. When MIB scan is positive, nodule can be malignant or benign, with an increased specificity and diagnostic accuracy if for diagnosis of malignant lesion if previous iodine or technetium perniciate shows a cold nodule. Thallium is another radiotracer not indicated in the current guideline, but there are few studies, Japan study, that demonstrate the useful in differentiating benign from malignant nodules, take advantage of its biological properties that are similar to potassium. So it's used for myocardial and renal medullary imaging, but also for tumor detection. In this recent study, retrospective study, the authors value the diagnostic evaluation of ultrasonography of dual scintigraphy, thallium and technetium, in differentiating between benign and malignant thyroid nodules. It's a retrospective study of 86 patients, and all patients performed before previously a 99 technetium pectated scan, and almost all the nodules are cold, and then performed a thallium scan with two phases, an early phase as seen in this slide, and a late phase. And then, after scintigraphy scan, was performed cytology. The thallium scan delineated two different patterns, a delay accumulation pattern and a persistent pattern. The persistent pattern was associated more frequently to a malignant nodule, instead a delayed accumulation pattern that was associated of a benign nodule. This is the imaging. In the upper part, we can see a delayed accumulation pattern with, on the left, a technetium scan with a cold nodule on the arrow, and a positive thallium both in the early and in the delayed phase when comparing to the surrounding tissue. And below, the persistent pattern. In this case, uptake is higher on the delayed phase when compared to the early phase. This is the table of diagnostic performance of ultrasonography and thallium scintigraphy. And I would just like to emphasize this value of specificity of persistent pattern that is very higher compare with the delayed cumulation pattern, and is equal to the value of specificity of the ultrasonography. So the authors conclude that the assessment of thyroid nodules using a combination of ultrasonography and scintigraphy may be useful for exclusion of malignancy. About Fdg-Pet, the American Association say with a strong recommendation that only in a case of focal Fdg-Pet with the nodules more than 1 centimeter in diameter is recommended an evaluation with final need aspiration. Says also that Fdg-Pet is not routinely recommended for the evaluation of indeterminate nodule, but this is a weak recommendation. The reason is because the use of Fdg-Pet is still controversial with heterogeneous result in all the scenario of the thyroid disease, is not routinely used, and the majority of the case, the findings are incidental findings, and the focal uptake is not strictly associated with malignancy, but also in thyroiditis and benign nodules such as Hartle cell adenoma, we can find focal uptake. So FDG is a diagnostic tool reserved for selected patients. This is a very recent systematic review and a meta-analysis about the performance of FDG in selecting thyroid nodules with indeterminated cytology candidate to surgery. This is the Poulet sensitivity, specificity, and predictive value. And this is the odds ratio value of 3.5 that indicate the moderate ability of Fdg-Pet to correctly discriminate between malignant and benign lesion in the case of a indeterminate final needle aspiration, and is a reliable option to reduce unnecessary diagnostic surgery because could prevent about half of surgery. But there is many limitations, like nodule diameter, like benign nodule with abundant intracytoplasmatic mitochondria that can do a focal uptake, and the problem of the standard uptake value, the submax cutoff, because is still present several differences in protocol and methods for quantification of this value. This is an example of Fdg-Pet and cytology, positive cytology and a positive Fdg-Pet with a focal paramedian uptake near the trachea, as we can see, with a submax of 8.4 at the cytology was a tier 4, and the histology said that the nodule was a papillary carcinoma. In this case, we have always still a focal uptake on the right lobe, but in this case, at cytology was a tier 2, so this is the case of benign hypermetabolic nodule. This is the case of not a focal uptake, but a diffuse uptake on the right lobe of thyroid, and at cytology was a tier 2, so a thyroiditis. And at the end, we can see a voluminous goiter with high diffuse FDG uptake with a submax of 28.8, and this is the case of malignant lymphoma. So the take-home message are scintigraphy scan can be requested after a thyroid nodule was discovered with ultrasonography and needs of further characterization to avoid or confirm a final needle aspiration, or after a cytological diagnosis of indeterminate thyroid nodules. Iodine 1, 23, and 23 represent the ideal tracer, but technetium 99 pertenectate is more available, less expensive, and gives less dose exposition to the patient. Technetium MIB could be used in case of cytological indeterminate nodule in non-oncocytic lesion, occasionally in selected patients, and FDG can be used in selected patients to evaluate cytological indeterminate thyroid nodule in order to avoid unnecessary diagnostic surgery. Thank you very much.
Thank you. Thank you, Elisa, for your complete presentation. So there is time for some questions. I've got a curiosity about, is there a cutoff values you would consider for SUV values in order to, yes, detect malignancy, associated malignancy?
In the study I've showed, the cutoff is from 2 to 5. Box, but there is no defined cutoff.
Okay, thanks. Questions? Mary? Yeah, of course. Mario, please.
Thank you. I am not familiar with the use of technetium, so we were just discussing if technetium is affected by the previous use of contrast material. Iodinated contrast material is obviously the obstacle that we face with the use of iodine. Can we use technetium in patients that had exposure to contrast material with iodine? Thank you.
Yes, there is no problem to the contrast. Technetium MIB or technetium pernectated? Pernectated. No, there is no problem.
Enrico Ragone, Napoli. Many compliments for your presentation. A lit question. When in ultrasonography examination, I see a nodular lesion, when I must the scintigraphy, the approfondiment, another approach, when I must or when I can?
When I have a suspect, radiologic suspect of the nodules, and when I want to exclude malignancy because maybe I suspect that there is an autonomous function of this nodule, and I want to indicate this autonomous function.
Okay, thank you. And in the clinical practice, there are the specific criteria for, I ask the scintigraphy, the aspect of nodular lesion in ultrasonography, the age of patients, because I ask in the clinical practice.
No, because as I say before,
yes.
I can do the scan before or after the eventual final needle aspiration. So there is no a guideline that indicates before or after.
Because in the clinical practice, I don't ask always the scintigraphy. I think in base over the aspect or margin of a nodular lesion, and
I think that when there is more suspect. At ultrasonography.
And there are the specific criteria. There are the specific criteria.
No. There is very individualized.
Agostino Andrade, Monsanto, Miami. In the United States, a final aspiration, the doctor will charge about $120, $160 per aspiration, and the pathology costs about $120 to $180. But the scan will cost $1,200 to $2,000. So is that the same price in Italy? Number one.
I don't know.
Because the conclusion of your wonderful presentation is that you do the scan in order to avoid a final aspiration.
Or confirm, to avoid or confirm.
Okay, so price-wise, in the United States, it's cheaper to do the aspiration than the scan.
I don't know in Italy the cost of the exam, but I think that avoid an invasive practice is better than to confirm.
Evelyn Sotma, endocrine surgeon. Thank you very much for your interesting presentation. I was wondering, in the FNAB Bethesda cytology results in favor of benign lesions, because of the size, as an endocrine surgeon, we find cancers in the Bethesda too. So would there be, to your opinion, is there a place for MIBI iodine scintigraphy in large lesions with the FNA cytology in favor of benign lesions?
For dimension, the criteria is the dimension.
Endocrine surgeons tend to operate on lesions above 4 centimeters because they say FNA cytology is not viable. So we need other arguments to say that it's really benign and it's not necessary to operate, because if we look at surgical series, even the Italian group with 200 patients, I think, in the lesions above 4 centimeters, Bethesda 2, and no ultrasound features of malignancy, there were up to 12% of cancers.
I think the problem of diameter is bound to the difficult to individuate the nodule at the previous technician scan. If cold nodule, very little nodule, it's difficult to sign the ROI for the nodule on the scan, on the MIBI scan. I think this is the problem, the main problem.
I have a question about the practice with your, for example, scintigraphy. You do for all of the nodules, thyroid nodules? You do this imaging, scintigraphy for all of the nodules, thyroid nodules, or only when we encountered with a decreased, for example, TSH, we don't use the scintigraphy in the nodules because the percentage of the nodules that are malignant is very low. And according to the, for example, clinical and ultrasonographic findings, we can choose that do the scintigraphy or no. And when the TSH is normal or elevated, we can do this, the scintigraphy imaging.
We do technetium pertenectated for all nodules. For all.
In some guidelines, this difference. And when we have encountered with a normal TSH, we do the scintigraphy because the nodules, we think that is cold. And when the TSH is decreased, we think that it's cold. In some guidelines, we use this practice.
We do it for all nodules.
You do all of the nodules, you do the scintigraphy.
But specificity is low. It's very low.
And about the price of this practice?
Very frequently we found a cold nodule, but benign lesion, not malignancy. We found very frequently cold nodules, but benign.
All of the cold nodules are not malignant. And
are not?
All of the cold nodules are not malignant. And the price is very important for the patients, I think. And in our guidelines, when encountered with a normal TSH, we do the scintigraphy, not all of the nodules. And we can choose the person that need to FNA according to the picture of the nodules, for example, heterogeneity and the size of the nodules, for example, gender of the patient, and something like this one. And we choose that who must be have an FNA. Your practices.
Okay. Elisa, thank you. In closing this session, I just want to remark that, yes, of course, scintigraphy and nuclear medicine techniques are not, required for all nodules. We have herds of nodules. We should, yes, not only for economic reason, but this fine needle aspiration, of course, can give an answer for most of them. So thank you for your update on this area. Thank you, Elisa. And so I think we have a coffee break now. So enjoy it.